Today, like most days, over 230 boys and girls will be born in Tennessee nurseries. Here lies the future of our communities, the teachers, doctors, businessmen and women, the mothers and fathers, the citizens who will lead our state in the coming decades. Unfortunately, of the children born on any given day, 2 will never reach their potential because they will not make it to their first birthday. If these babies were born in certain Tennessee zip codes, up to 5 would not live to the age of 1. As these babies grow into busy and curious preschoolers, more problems will soon arise. Out of the children born today, 3 will likely be expelled from preschool because of already developing behavioral problems. By the time our future citizens reach 2nd grade, we can expect 2 students out of most classes will have asthma. When our children reach their 13th birthday, we can expect they already will be experimenting with risky health behaviors. Out of a typical middle school class, 4 will have already smoked their first cigarette. 5 will have already had their first drink of alcohol. By the time our kids have reached their high school years, many will be at risk of serious health problems. In a typical high school class, 9 will be overweight. 4 will have considered suicide within the past year. 5 will be daily smokers at some point, and 5 will have already had 4 or more sexual partners. Whose children will defy the odds?
Major funding for NPT Reports Children's Health Crisis is provided by the Healthways Foundation, addressing the critical issues of children's health and public education, the Nashville Healthcare Council, the Monroe Carroll Jr. Children's Hospital at Vanderbilt, getting children well on their way, Vanderbilt University School of Medicine, Department of Pediatrics. Additional support provided by the Orrin H. Ingram Fund and by members of NPT. Thank you.
When I hear statistics like those at the beginning of the program, I know too many of our children are not getting a healthy start in life. Hi, I'm Kimberly Williams Paisley. Of all the states in the U.S., Tennessee fares among the worst in almost all leading indicators of children's health. Why do we rate so poorly in these rankings? What can we do as individuals and as a community to improve our children's health? This program is the first in a series of 7 looking at the problems our community faces raising healthy children. Future documentaries will focus on specific issues such as childhood obesity and infant mortality. The project also includes an informative website, ongoing health updates, and extensive educational and outreach efforts. As a mother, nothing concerns me more than the health and well-being of my children. I'm privileged and committed to be a part of this thorough effort to bring our community together and learn more about the children's health crisis in Tennessee.
In September 2009, the city of Nashville held a birthday party for the children of one neighborhood in North Nashville. At this celebration, Mayor Carl Dean signed a proclamation declaring Nashville would become
the healthiest place in Tennessee for all infants to be born.
In a city with some of the most dismal health statistics for its children, this will be no small task. And for the children of this neighborhood, reaching their first birthday meant beating some of the worst infant mortality statistics in the state.
In the U.S., Tennessee is probably one of the worst places to be born. You can do better if you were born in almost any other state in the country than in Tennessee. We tend to rank somewhere around 4th from the bottom as far as health of our babies. Memphis, unfortunately, holds the title of being the worst in the country as far as a city to be born, and we're not too far behind them. We have areas of our county not too far from some of our major hospitals where our rates are equal to those of Sri Lanka.
I was 22 weeks gestationally, and I noticed bleeding when I was at the mall. Went to the bathroom, and I called my doctor, and he told me to go to the hospital so they can just check me out. I thought I was going to be in and out, but I ended up staying because they had said my water bag was leaking, I believe. They took me up to a room. My head was down here, my legs was up in the air. So they were trying to keep the baby in. So I guess they were trying to let gravity do its part. So I was like that for about a week and a half. They were telling me about them not resuscitating at 22 weeks. They were giving me options to do a DNC, pretty much to get rid of them, I guess. Or to have them and let them die in their arms, have them and let them die in my arms. It was hard. I was still 22 weeks when I started feeling contractions, about 11 o'clock p.m. I guess I turned 23 weeks at 12 a.m. and then I had them at 12:18. So I guess if I'd had them 18 minutes earlier, they wouldn't have resuscitated. This is a picture of Donovan. He was about 9 hours old. He's on the ventilator. His eyes were still sealed closed. His ears were still sealed to his head because he wasn't really just fully developed. And it took a few weeks for it to kind of separate from his eyes to separate and his ears to separate from his head. You really can't tell here, but his skin was real thin, red, and transparent. You can kind of see his heart beating, lungs working through his skin. This is the point where I couldn't really touch him, and the nurses even did minimal touching because it would have tore his skin. These were some of the Pampers that he wore. These were actually a little too big for him when he was first born. This is his first footprint. I remember his progress was up and down. He had got down to like 14 ounces. He only weighed to like 14 or 15 ounces at one time. One day he almost passed. They gave me a room because they didn't think he was gonna make it through the night, so they were like, trying to save him, and he pulled through. So it was up and down. And this is when I was kangarooing him. It's supposed to emulate the womb, putting him inside of your shirt, skin to skin. I was very nervous about his long-term issues because that's what they were feeding into my head before I had him, that he might be delayed, he might have brain bleeds, which he did.
The earlier they're born, the more chronic health problems they're going to have, and the more potential for cognitive difficulties they're going to have also. The more premature babies that we have being born, even though some will do great and be the miracle story, there is still a lot of others that don't have those great outcomes. And those children get older, they go to school, they may require additional resources, they may require medical procedures at schools because of some of their chronic health issues, they may require special education, additional services, just to try to get them up to par with their classmates that were born full term.
There we go.
In Middle Tennessee, and like the rest of Tennessee, the problem is that babies are being born way too early and they're being born too small. And what we know that determines that is mom's health before she ever gets pregnant. And so it is certainly about getting high quality prenatal care and getting moms connected to care, but it's more about making sure that mom is healthy before she ever conceives that child. And so that means that we address problems like high blood pressure, other heart disease, diabetes, obesity, asthma, things that put mothers at higher risk for not being able to carry a baby to term.
It means health in the broader sense, whether or not that's the community, that's the stress level, the available diet, the ability to exercise, the access to cigarettes, alcohol, the risky behaviors, all of those things all bundled up together. If you are not healthy for, we'll say, 25 years and then get pregnant, there's nothing that can be done in 9 months that's going to undo everything that's been done.
Keisha planned her pregnancy and was in good health prior to conception. What she didn't realize was just being African American could have a significant impact on her baby's chances for survival.
If you were to take an African American woman who started prenatal care in the first trimester, she actually still has a higher infant mortality risk compared to a white woman who starts prenatal care in the first trimester, or even a white woman who starts prenatal care after the first trimester or had no prenatal care at all.
Unfortunately, we have probably a twofold disparity in Davidson County. So an African American baby is twice as likely to die than a Caucasian baby within our city. And unfortunately, this is true on most large urban cities. So we're not any different in that sense, but it's still very concerning.
In fact, studies have shown that the experience of racism increases your likelihood of having a very low birth weight baby by about threefold. The experience of racism increases the release of stress hormones from the mother. During pregnancy, these stress hormones could cross the placenta and in a way bathe the baby in all of these hormones. And not only could these stress hormones precipitate preterm labor, they could actually affect the way the baby's brain develops. What's going on during pregnancy is mom's trying to get the baby ready for the outside world. If the outside world is stressful and hostile, mom's going to try to get the baby ready for fight or flight by turning on those genes that prepare the baby to fight or flight. Now, that may confer some survival advantage for the child in the short run, but could certainly have some very serious long-term health and developmental consequences.
Survival for Donovan Bass meant spending 7 months in the hospital, enduring multiple surgeries, and receiving intensive care even after leaving the hospital.
He had at least 4 to 5 doctor's appointments a week. He was on an apnea monitor, a pulse oximeter, oxygen. So I'm carrying all that plus a baby bag, plus a baby, to 4 to 5 appointments a week. He was on 6 or 7 medicines. Once my time was up to go back to work, he had a home nurse for 2 years. He needed help with the feeding machine. He had a feeding machine, I forgot about that. With the oxygen, the monitors, she had to just help with all of that. So they were here 12 hours a day, Monday through Friday. Donovan is now 4. He has a speech delay, but now he's speaking a whole lot better than he did before. He has a speech therapist. He had a physical therapist because his balance was kind of off. Hey, Donovan! He was kind of delayed on the potty training, and he didn't walk until he was like maybe 2.5. It seems like he kind of learns on the same level. He may be a little bit behind, but he's doing better than I thought he'd be doing, you know, as far as his mentally.
Bye, buds.
He's very outgoing. He's a very active child. He loves reading. His favorite thing to do is to force you to read to him and watch Happy Feet.
We have an entire generation of children that are behind the curve, behind the 8 ball. And if you look at that as far as graduation rates, that may affect how many of our kids are able to graduate on time or graduate at all. So in a sense, we are putting our entire generation or our entire future at risk by not taking care of the health of our children, and that includes making sure that they're born on time.
Today, many of us are beginning to recognize that to expect prenatal care in less than 9 months to reverse all the cumulative impact of stress, of poor nutrition, of poor housing, of poor environment, of poor education and joblessness is probably expecting way too much of prenatal care, and that if we're serious as a nation about improving our pregnancy outcomes and reducing our disparities, we really got to start taking care of women and families, not only during those 9 months of pregnancy, but before pregnancy, between pregnancies, beyond pregnancy, and indeed across their entire life course.
For children born in the year 2000, this is the first generation of children not expected to live as long as their parents.
We know that right now about 30% of Tennessee kids are in the overweight category, which is basically tripled in the last 30 years.
Being overweight or obese puts our youth at risk for serious health complications like bone and joint problems, high blood pressure, heart disease, and diabetes.
If the current rates stay where they were, anywhere from 1 in 3 to 1 in 4 kids born in the year 2000 will have diabetes, which to me is a staggering number that 20 to 25% of people will have diabetes at some point in their life. That means 1 in 4 people.
If you're African American or Hispanic, that number is 1 in 2. And what we know about type 2 diabetes is that it used to be called adult onset diabetes. Never saw it in children. And what does that mean? Well, type 2 diabetes and diabetes in general, leading cause of adult new onset blindness, leading cause of non-traumatic amputation, a 1-to-1 correlation between diabetes and heart disease, leading cause of end-stage renal disease, which subjects you to need kidney dialysis. It's not a pretty picture.
If the average person that gets diabetes in their 50s might start experiencing some of these things in their 80s or so, it's a lot different than someone who may be 11 and by the time they're 40, they're losing their eyesight, they're disabled, they're on dialysis, and they may have lost a leg or a foot or things like that.
Faith is very outgoing, friendly, positive attitude, very high self-esteem. She takes care of things. She likes to help me do things.
I'm 10, I'm in 5th grade, and I like to play sports. I like to play volleyball and softball, and I'm gonna play soccer this year.
Hey, why don't you get those shoes off for me and then stand on that scale?
It started with her routine annual visit, yearly visit at the pediatrician. And they were monitoring her weight. And then I would say in the last couple of years, they noticed that it was continuing to go up. And so they referred us to Vanderbilt.
So Faith will have to choose which ones are her favorite and then commit to that goal.
We have basically modeled our clinic on what's called a multidisciplinary or a team approach. So we have a registered dietitian that sees our patients in the clinic. Many of our patients have joint problems or they don't have exercise capacity, so we need a way to assess that. So we have a physical therapist or an exercise trainer sort of work with the kids on a 1-to-1 basis about how fit they are, helping them brainstorm what is available in their neighborhood. So, how are things going?
Good.
And then they also see me, the physician, and I also screen for all the conditions that we're starting to see with obesity, help them set goals and sort of figure out where they are they ready to change, are they ready to make the next steps, and really trying to empower them to sort of take some simple baby steps to start to make some real habits stick.
I think one of my favorite is going to talk with Dr. Plemons. I like doing that.
What'd you get to make?
We made like vegetable quesadillas.
That sounds pretty good.
Mm-hmm. He'll talk about how much weight I've lost or gained, or if I'm the same, or fun stuff too sometimes. Like what book I'm reading, or like what kind of sports I'm playing right now.
Go ahead and grab a seat for me, will you?
At each visit, Faith meets with Eric Seguin, an exercise physiologist.
We go around the track and we record how long it takes me, and I get better every time.
You're gonna go ahead on the left, okay? Go first.
One day there was this person at the Dione Center, and he said that he drinks a lot of juice every day, and if I knew, like, if that was good or bad, and that he probably didn't know when he was, like, in his 20s. And he said that that's a good thing that you know.
Put your racket out in front of you.
Faith has said that she's glad that we're doing this because she has learned, and that she's glad that at her age she's learning what she's learning because she sees other children that are older and they're struggling now, and it's harder after they get older.
Land.
When I see a 5-year-old kid for obesity, I honestly not need to see the 5-year-old kid. I need to spend the time with the mom and the dad, because those are the easy ones to fix. Those are the kids that we love to see. If you make 2 or 3 small little changes, you're going to be fine.
Good job.
That's very different from the 15-year-old who has been watching 3 or 4 hours of TV since he was 5. The family's entrenched and kind of, this is how we eat and this is how we operate. Those are much more challenging cases, and we know that the success rates go down. We know that if you're a preschool kid, you have about a 20 to 30% chance of being overweight as an adult, but if you're overweight in your teens, you have about an 80% chance of staying that way.
By going to the dietitian, I've learned, sweet tea, you shouldn't be making sweet tea at home, and that was one thing that we all cut out, was sweet tea. We eat a lot of chicken, and where we all like steak. One of the biggest complaints has been the sodas. My husband, for example, was a big Coke fan, and he's now drinking Coke Zero, which has been a good change for him. Thank you. One of the things I've done is I've stopped cooking bread with dinner. Knowing that that is one of Faith's weaknesses, I've stopped doing that.
The Southern sort of lifestyle has changed. People still sort of eat, typical Southern fried kinds of foods, and that was probably okay when you worked on the farm with your family and you hoed, 3 acres a day, but now we know that lifestyles are mostly sedentary. We know that kids don't walk to school like they did 30 years ago. Even just sort of simple things like walking to school back and from probably burn a significant amount of calories that doesn't happen anymore. So the activity and what you burn has certainly changed in the last 30 years, but probably what you take in has not.
It's been a life-changing situation for all of us. We're all eating healthy, and we're all, exercising, and even the teenagers are out going to the Y.
We're not putting kids on diets, we're not restricting calories, we're saying that, yes, everybody needs to eat more fruits and vegetables. And we know that if you do that, you actually lose weight. And that would also be good for everyone in the family.
We can say all day long, you need to move more and eat better. Sounds pretty simple. But if you don't have access to fresh fruits and vegetables, that's a barrier. If you have to take 4 bus transfers before you can get to a grocery store that sells fresh vegetables or even skim milk, that's a barrier.
When I was still learning how things worked, I would say, you just need to eat healthier, and you need to quit drinking those sodas, and you need to exercise more. And if you stop to ask the questions, well, why aren't you doing those things? You find out that if you live in the Vine Hill, Houston community, you may have a convenience store as your access to food, and because the bus routes have been cut, you may not have access to get to the grocery store where you can buy fresh fruits and vegetables. And so if you don't have a car and you don't have bus transportation, you're stuck with getting food from where you live, and that may not be the healthiest food.
In Nashville, there are 4 neighborhoods without a major grocery store and with limited bus service. East Nashville around Casey Place, the Napier Homes area bounded by Interstates 40 and 24, 3rd Avenue South, and Stanley and Orr Streets, the Edge Hill neighborhood, and North Nashville between Whitebridge and Rosa L. Parks Boulevard. Experts refer to these areas as food deserts.
If you go to a convenience store in a Nashville food desert neighborhood with $10, I think that you'll find it is much easier to provide for your family calories that are empty calories, chips, soda, snack foods, prepared foods, than it is to find what you need to prepare a healthy meal. Healthy food frequently costs more in general, and definitely costs more in the kinds of stores where people who don't have access to a full-service grocery store shop. And it's important that we look at strategies to change food environments in addition to talking with people about changing their individual behaviors.
So I think it really calls on us to, one, understand that community plays a much larger role in health than we may have previously thought. It also means that those of us in the medical community need to be vocal advocates. It's important for me to have my stethoscope and listen to hearts and lungs and look in ears. All right. But if I don't go to city council and say, we need more sidewalks in this neighborhood, if I don't go to state policymakers and say, we need policies that support placement of nutritious foods in neighborhoods, if we don't go out and advocate for children, then we've missed the boat.
The hardest thing would probably be the 6 carbs a day. I'm doing pretty good, but sometimes if you want to have an extra, you can't.
And my advice to other parents would be to embrace it and to accept that your child has a health issue with their weight, to educate everyone in your family. But you can't do it on your own. And the sooner that you make changes, the better. And everyone has to make changes. And that's not easy.
There are estimates that there are many, many children in the community that have unmet mental health needs or undiagnosed mental health needs. The interesting thing is, if you talk to teachers or you talk to pastors or you talk to youth group leaders, many of them can point those kids out and say, something's not exactly right, or I have concerns about that kid, and yet they may not be connected to care.
The untreated mental health issues in kids can lead to a lot of different problems. It can lead to problems with the juvenile justice system, it can lead to problems in the school system with academic difficulties, bullying, truancy.
What we know is that more than 75% of the children in the juvenile justice system have a mental health problem. And somewhere between 35 and 50% of the children in the child welfare system have mental health issues.
In 2009, the National Alliance on Mental Illness gave Tennessee a grade of D for its efforts in providing mental health services.
I have bipolar disorder, and it just means that, I have a lot of really bad mood swings. I get really depressed all the time. Sometimes I can get out of bed, sometimes I can't. I go to school, and sometimes I sleep all day at school, or sometimes I can do like a lot of work. It all depends on how I'm feeling that day, because I can feel completely different one day to the next. And since I'm never in class, I have to get all my work, and I have to be able to do it all by myself. So it's been a struggle. It's just, without anybody teaching me anything, I have to do all my work, and it's difficult.
She'd always been a great student. She got up, she went to school, she did her homework, she made straight A's. She was also more quiet, she was more set off. She's always been a writer since she was about 4, 5, and always a big reader. So for her to sit for 3 or 4 or 5 hours reading books and being quiet was just nothing unusual. She attempted to commit suicide in 2006. And that's actually the first time we really realized that something was wrong.
I just been feeling really depressed, really awful for a while, for like really, really bad for months and months. And I was just like, okay, if one more thing happens, then I'm gonna try to kill myself. And then, I got in an argument with my mom, and I was just like, that's it. And I'm so sick of this. And I tried to kill myself. And so I took about 50 or 60 pills, but I actually ended up vomiting the whole entire night and the next day. So, I knew, it didn't work. And then, so I texted my friend, and I was like, I feel really awful right now. I just tried to OD, and it didn't work. And so that's when she got really upset and told her mom.
April's parents immediately sought psychiatric help for their daughter. Initially diagnosed as depressed, April took increasingly strong doses of antidepressants, which for someone who is bipolar can make things worse. She also worked with a therapist.
She was kind of just a therapist that said, tell me about your feelings and like, how do you feel about that kind of stuff. So she never really gave me any skills to deal with what I needed to deal with. And so after about a year, I said, you know, I'm feeling really awful again, this isn't working.
She was in bed about 20 hours a day. She wouldn't even come down to eat. She couldn't even go to the bathroom. She just was just laying in bed for hours and hours. So we went online and we were looking for a day treatment program for her, and there aren't any day treatment programs for teenagers in Nashville, and so that made that very difficult. But we did find a program at Vanderbilt, and when I called, they said it would be about 60 days before we could get an appointment. And so we also knew that wouldn't work, but we got lucky. They had a cancellation, and so April was actually able to go the next week.
There's a real shortage of people to treat children's mental health issues. I think most people that see children have waiting lists that are probably months long. And so that can really make it a challenge when you finally decide, you've made the decision, you're going to seek treatment for your child, and then you're told, okay, well that's great, but let me put you on this list and we'll call you in a few months.
It's a very critical time for families when they first learn of the mental health problem. And as they struggle in a system to find services for their child, what we find is that families get even more desperate. The problem that we have in most of our communities in Tennessee is that our services are still fragmented. So families struggle to get heard, to learn what their child needs, and to work carefully through the system to get that coordinated service that their child needs.
The Alonzo's persistence paid off with a new psychiatrist and the first suggestion of a different diagnosis, bipolar disorder. But initial attempts to use a new bipolar medication caused too many side effects. When suicide thoughts returned, April agreed to enter the hospital, where the new medications could be more safely administered.
And so by about the third day when we could pick her up, she looked like a totally different person. You could just tell. And she knew it too, and she said, I can feel it. I feel different. And her face was clearer. She just looked wonderful. It was something we hadn't seen for a really long time.
April has continued to improve, but the process is not linear. She has ups and downs, and her issues may change as her body continues to grow.
As she's going to enter her 20s, we're going to see more of the manic stage, and which we haven't had to deal a lot with. She's only had one major manic episode. She also has anxiety and OCD. Some of the medications help with that, and so she's become a lot better. Some of them, then we just have to increase as we go on.
We say my medication is 25% and the hard work I have to do is 75%. Because I have to fight my brain. My brain is telling me like, oh, I can't get out of bed. I just can't do anything. But I have to say, you know what, for the best, I have to get out of bed. I have to go do work and I have to get out. And I mean, when you're fighting your brain, you have to learn these skills that'll help you understand, what your brain is telling you is wrong. And I just hope people will realize that, you can't see it, but it's agony, and we're working our hardest to get better.
It is.
I'm not ashamed of her diagnosis, but we share with some people, and then you can tell the next time when they don't want to know any more about, so they just won't ask how April is, because I think it's scary. And so I think the choice that they're making is not to make that part of their life or their understanding, and that's okay. But it's difficult, it's hard, because it hurts my daughter.
Mental health problems are real, and I think that's difficult for a lot of people to accept, particularly mental health problems in children. Those are real and they're treatable, but we do not view them the same. That is the stigma of children's mental health issues, is that they aren't viewed as the same as you would if it were a physical illness. If it were a physical illness, you would want to identify it early, to make sure you got early treatment of it, and to make sure that the treatment was effective.
I think sometimes parents maybe wait too long because of stigma and because of their own fears about what that might mean. They talk to their family and friends who were not supportive of getting additional help or treatment. I think parents are very afraid that their child's going to be started on medicine, and they're really afraid of what medicine might mean or might cause. These mental disorders definitely have a biological basis, just like, diabetes or asthma. And when I talk to kids about, why do they need to take medicine, or why do they need to get treatment, and I use those same examples. I tell kids, it's no different than a child who has asthma or has diabetes and has to take their medicine every day. It's the same as that.
As April continues to improve, she can begin to see beyond the present to her future.
I would love to be a writer. I kind of picked a random place that I would love to live, and I picked Nebraska, but it's really hard for me to be alone right now, and it's hard for me to think about having to pay all my medical bills and buying all my pills and getting my therapist and psychiatrist. So I would love to be a little more stable and be able to live on my own and, have a really fun and cool life.
I know one of her fears is that she will have to live with us indefinitely. So my hope is that she will become independent, that whatever her dreams are, that she will accomplish them. Just that she loves life and she enjoys life.
Since we are part of a larger community, how one child is doing will probably, eventually affect us all. A lot of parents I see are surprised that they never thought this would be something that they would have to struggle with or a family member would have to struggle with, but that they were really glad that treatment was available when they needed it.
But funding is the biggest barrier. So the challenge is to incentivize the payment system to actually pay for what works. Now, fortunately, what works are the most inexpensive services. The services for the training the parent, education, skill building for the child, instead of the very expensive high-end services that we're so used to paying for, like residential treatment and inpatient services. But it takes a change. It takes a change in how we view serving children, and it makes a big change in what kinds of services are funded.
If you think that a generation of future leaders, of future workers, of future scientists, professionals are not healthy, if you're not healthy, then the chances are you're probably not doing really, really well in school, so your academic performance may not be as good. So we're really affecting our future and limiting the future of Davidson County of Tennessee by not taking care of our children or our children not being healthy.
The health in the community determines workforce, it determines productivity, it determines quality of life. All of those things are very important to businesses. Whether they're already here or they're moving here, they want to come to a healthy community because it's a productive community. So businesses ask us when they're coming to town, what's the health quality of young people? And we have to tell them that we have plans to improve it.
75% of the dollars spent in the federal healthcare system are spent on chronic disease.
Hello.
And when you look at investments in health, only about 3 cents of every dollar goes to prevention. If we don't make some substantial changes now, those numbers are only going to climb, because remember, the folks that are within the system now, the chronic disease toward the older age, we're now seeing that chronic disease in teenagers. So again, multiple years of cost going forward, and we absolutely cannot stand for it. Children deserve better.
health is an underlying thing for everything. When you and I don't feel good, we don't do as well in our job performance. If a child's coming to school and they're hungry, if a child's having to come to school and they've been sick for 3 or 4 days and not had any access to health care, if a child has not been taught healthy educational or recreational practices as an outlet, a way of relieving stress, if they don't have healthy practices in terms of how to recognize and take care of their own bodies, they will never know how to go on and be successful into their adult lives.
As principal of Glencliff High School, Tony Majors wants all his students to graduate and be successful.
What oath did they take? What did we talk about?
Faced with the task of turning around the academically struggling school, Majors looked closely at the high rate of absenteeism. He quickly realized attendance was often related to health.
We are probably one of the most diverse schools in the state of Tennessee, if not the most diverse. When you have those circumstances, being a high poverty, highly transient, highly immigrant population, number one, a lot of these people don't have access to health care. So that became an immediate need as a means of increasing attendance and improving the overall quality of the health of our students.
Majors approached United Neighborhood Health Services about opening a clinic in his school.
United Neighborhood really likes to focus on the high school years. That's a time when we find that fewer young adults actually get health care. It drops to maybe 30–40%. During the course of a year, we'll actually see a doctor, and they'll see a doctor for being sick.
Good morning, how are you? We actually assess students when they come for any reason. If they come for a physical exam or a sick visit, we assess the need for education about hygiene education, nutrition, sexual education, and also behavioral care and substance abuse. So we provide all those kind of services, and we try to have the opportunity to talk to them and help them. Okay? Do you smoke?
Yes.
How much do you smoke?
Are you drinking? Are you depressed? Are you anxious? Have you thought about suicide? What bothers you? So we're able to ask all the prevention questions that help young people of that age grow up. These are young people who are changing very rapidly. Their biology is changing, their psychology is changing, and oftentimes a medical provider can be a very trusted person because we're not judging, we're just helping them to understand their lives.
The clinic is far more than just medicine. It also has a mental health component. It also helps support our career academies with our Health Sciences Academy here at the school, so it has an instructional component as well. It has become a day-to-day and vital part of our overall operation.
Mr. Majors and the Glencliff High School Clinic have done something really revolutionary in Nashville. They not only serve the students in the school, but there's actually an outside entrance so that we can actually serve the community, including the parents and siblings of those students. And the clinic can actually stay open year-round. Even when the school is closed, people have access to the clinic. So we're really helping the community improve its health as well as the students. So what we actually find is the students at Glencliff High School, we're going to be their major source of health care.
The clinic was only one part of a comprehensive plan to change the culture of the school. Majors harnessed the resources of multiple outside partners to address everything from school lunch nutrition to assistance for teen parents to access to recreational activities. His efforts exemplify the Coordinated School Health Initiative, which aims to improve academic achievement by addressing the health needs of students across academics, recreation, and the broader community.
I've seen a great change in our upper level students, our juniors and seniors, and their now commitment to different initiatives, how they actually use their pedometers. They actually have a reference point of how many steps did they have today. They can actually have discussions surrounding healthy food choices. There's a much stronger commitment to school as a community, eliminating the cultural barriers, dealing with gangs and other things that are disruptive of the school environment, and a commitment to student leadership. Students now know that they have a voice. They also know that we are committed to their overall well-being, not just grades.
High school graduation is the best predictor of good health that we have. So we want children to succeed academically. So partnering with schools is just a natural for healthcare centers. That's where children are 8 hours a day. That's where people are identifying a lot of health issues. And I do think that's the only way we can accomplish what we need to accomplish.
Do you need sand? We need sand in each one of these.
If you really want to address health and wellness, do it holistically. Access to mental health, access to physicians and medical assistants, but also recreation, also nutrition, also look at educational opportunities for students.
What is the #1 killer of teens?
My primary job as a principal is to educate students, but I've recognized that health and recreation and access to opportunities for kids is also equally important.
If I had one sort of charge for policymakers that would make all our children healthier, it would be to fix poverty. And that's sort of a joke because we know it's not as easy as that. And yet we know that poverty and health are inextricably linked. Families that live in poverty have difficulty accessing care, they have difficulty complying with care plans, things like getting medications or getting necessary treatments. Many times they live in the neighborhoods that don't foster healthy choices, neighborhoods where there aren't fresh fruits and vegetables, where there aren't safe playgrounds. They may live in neighborhoods where there aren't bus routes to be able to get back and forth to care.
I think we've underestimated the association of poverty and stress. Stress on the family, stress on the children. A lot of the children's stress comes from environmental issues, violence in the neighborhood, dislocation of families. We know that poor people, at least a quarter to a half, probably move every year. So there's a lot of mobility both within housing and in the education system and in the friendship networks. So poor people just have a lot stacked against them in terms of health.
It's challenging to think that the number of children who are living in poverty is growing. It's certainly going to continue to challenge us in the health profession to make sure that kids are healthy.
When you look again at those determinants of health, education, violence, poverty, we need to look at job creations, all of that plays a part in improving the health of children. So there's not one silver bullet. You can't give one answer for the one thing you would change. Because this is like a jigsaw puzzle, and each piece by itself might be a very good piece, a nice piece, but it's when you bring all those pieces together that you can see really the beauty of the total picture.
We have to make a decision. We either decide now that we're going to address the needs of community health and the health of our children, or we will have to pay for it later.
Clearly, changing the trends in our children's health will be a long process, but we can't afford to sit idly by. Our children need us. Their future depends on what we choose to do in the present, whether it's eating better as a family or working to improve food quality and healthcare access in our community. Please join me in learning more about the children's health crisis in Tennessee and what you can do about it by tuning into NPT's ongoing coverage and by visiting us at wnpt.net/children's health. Thank you.
Major funding for NPT Reports, Children's Health Crisis, has been provided by the Healthways Foundation, addressing the critical issues of children's health and public education, the Nashville Healthcare Council, The Monroe Carroll Jr. Children's Hospital at Vanderbilt, getting children well on their way. Vanderbilt University's School of Medicine, Department of Pediatrics. Additional support provided by the Orrin H. Ingram Fund and by members of NPT. Thank you.